This is part 2 of the June 27th, 2024 COVID vaccine meeting by ACIP. Picking up where we left off, I thought it was very interesting to see the Pfizer Moderna Novavax breakdown by the VSD program, where Pfizer is making up the majority of doses for the COVID vaccine, about 2.5 million. Moderna is following far behind at 240,000 doses, and Novavax is only around 3,000 doses. But again, the VSD program does not represent the entirety of the country, but instead these states highlighted in light blue. So don't quote those numbers, just use it as a trend. Next, they again emphasize this finding that for young people under the age of 17, 50% of those hospitalized between July 2023 and March 2024 had no underlying conditions. For those that went to the intensive care unit, 40% had no underlying conditions. And for all hospitalized cases in this age group, 18% were severe cases, showing both that young people can be hospitalized for COVID, that you don't necessarily have to have pre-existing conditions for this to be severe, and that these young people aren't protected from severe disease simply by being young. The next thing I'd like to show is that getting vaccinated for COVID and having multiple vaccines for COVID results in significant reductions in post-COVID complications or long COVID, where we're seeing about a 33% reduction in adults and about a 40% reduction in children. The next point raised by Dr. Lakshmi Pangayotakopoulos was the observation that COVID-19 associated deaths occur all year round. During the active question section following the evidence recommendation section of the meeting, one of the speakers emphasized the fact that 95% of the over 3,000 public comments related to COVID that they had received was in favor of a universal recommendation, demonstrating that us showing up and making our comments is very effective. So we all need to keep doing this. Another point raised was the need to emphasize by the CDC why people should be getting this year's vaccination, saying in short that you need this year's vaccine to be protected against this year's disease of the virus. And a point was also raised at this time to move away from the infection-induced immunity language, because if prior infection or distant prior vaccination protected you against new variants of COVID, then you wouldn't see a change in relative vaccine efficacy. If prior vaccination and prior infection was enough, we wouldn't see a relative change in the vaccine effectiveness, but we do, which emphasizes the need for continuous updated vaccinations. Next, we're going to look at COVID vaccine implementation and risk factors, in addition to physician perspectives, where we see lower income individuals have a high concern of being hospitalized for COVID and for giving COVID to other people, meaning that there's high interest by these communities to get vaccinated against COVID, which is incredibly problematic because with the ending of the Bridge Access Program, adults will now no longer be able to get COVID vaccines affordably, meaning for free or at low cost. Next, we have seen a precipitous drop-off in COVID vaccination uptake, where currently they estimate 28% of the population is up to date on their COVID vaccine. But what they really mean by that is 28% of the US population is estimated to have gotten a COVID vaccine this past year, where from this omnibus survey, about a third of people will get the vaccine, about a third of people are unsure, and about a third of people definitely will not. And this is pretty consistent across the board, where of the people that would not, they're the most concerned about side effects or the vaccine being ineffective, or the belief that their child is unlikely to get very sick from COVID. And as we've demonstrated by this point, the side effects very minimal. The vaccine is quite effective for at least 4 months in protecting you against hospitalization and severe illness. And children do in fact get very sick from COVID-19. So it's important to emphasize that this is a misperception by the public due to lack of clear communication by both the CDC and then physicians that interact with the public on the day-to-day basis. Where again, it's important to note that there's accessibility barriers. For instance, vaccine coverage was higher in urban suburban areas compared to rural areas, where children with private health insurance had a higher vaccination coverage than uninsured children or those covered by Medicaid, and that also vaccine coverage increased with increasing household income, where again, all of this emphasizes the fact that if people can't afford the vaccine, they won't get the vaccine, and if you make the vaccine affordable, more people will get it. Where again, to emphasize the barriers to vaccine access include the financial burden for both healthcare practices and individuals, the fact that fewer primary care practices even carry the COVID-19 vaccine, adding literal physical barriers such as travel time and the additional costs that might be accrued from that travel to get to a potentially not close location for vaccination. The fact that 25 to 30 million adults have no health insurance in the US, and that the Bridge Access Program is ending in August, which will result definitively in inequities to vaccine access. However, eligible uninsured and underinsured children can still receive COVID 19 vaccines through the Vaccines for Children's program, and COVID vaccines should be available to most people that have private health insurance, Medicare, and Medicaid plans. Next, we have to shake our fingers and chastise physicians. As of May of this year, only 21% of patients reported their physicians even recommending the COVID 19 vaccine, where even for the most at risk population, for those over 65, only about 41% received a referral from their provider, and half that number, about 22%, received it through their pharmacy or pharmacist. And for adults below the age of 65, this is even less, where 18% had a recommendation from a provider and 15% had a recommendation from a pharmacist. And when these providers, these physicians were polled and asked why they're not recommending COVID 19 vaccines to eligible adult patients, they listed reasons such as the patient will refuse the vaccine, patients are tired of hearing about COVID 19 vaccines, patients are getting tired of vaccines in general, that there's relatively high vaccine hesitancy in the age group in their community, which is just truly just a bunch of BS. They're essentially lying and lazy and uninformed. Where one of the ACIP members brought up a smoking analogy, stating that even if it's like the 16th time, you keep bringing it up because people do come around. So you should keep offering vaccines to patients. And that generally speaking, there is no reason to not get vaccinated. Where the quote from the meeting is, they are either making this up or are uninformed. And then the other reasons in this list, in terms of cost affordability, should also emphasize to both the manufacturers and to the CDC and to the US government that the uninsured are not getting vaccinated simply because they can't afford it. And for some reason, despite this, and despite knowing this and having the data for this, we are still cutting the bridge program, ultimately concluding that vaccinations save lives, but are not enough when they are not used. For our estimated timeline provided by the CDC and the FDA, the current language that was approved during the meeting was to give COVID vaccines for the 2024-2025 formulation to everybody 6 months and up. The vaccines from the manufacturers should be available to ship potentially mid-August to late September. And once these vaccines have shipped, providers would be able to administer the vaccine in offices 1 to 2 weeks after the FDA action, meaning that once the vaccines have shipped and are approved to be available to the public, it'll take about a week to 2 weeks to make them actually accessible to everybody.